Hello again, everyone. Oh, gosh, I'm loud. Wasn't expecting that. So as Angelica has just said, we're going to be elaborating more on this concept of harmonizing global credentials for the global health workforce. I'm delighted to say that we can join to the panel Isabel Mestres, who is the CEO of City Cancer Challenge, or otherwise known as CCAN, Dr. Neka Mobison, who is the CEO and co-founder of MDoc Healthcare, and Dr. Guillaume Duarte, the Executive Director for Unite, the Parliamentarians Network for Global Health. Welcome to you all. Microphones are all on the chairs. Isabel, let me start with you. So much talk when we're thinking about harmonizing credentials about the pros and the cons of that. The fact that there's a risk of brain drain, of this knowledge drought of skilled professionals leaving their home country. But on the flip side of that, the benefits that could be there of suddenly giving exposure and reward to otherwise underserved and under-recognized professions. How should all of us here navigate that balance?
Thank you. Thank you so much for inviting us. And let me just give a bit of 2 minutes to understand my response. So I am the CEO of City Cancer Challenge Foundation. It's an organization that was born from the Union for International Cancer Control in Geneva. And our purpose is to support countries in low-resource settings to improve access to cancer care. And we do it from a full system approach, which is part of the conversation we're going to have. And in order to address the complexity of the system, we do it from a city-level perspective. Because in the city, that's where the workforce is, where the public, the private, the academia, civil society is, and the whole patient journey. We can track it and understand what are the gaps and work with the local stakeholders to actually come up with solutions that work for that context and elevate it at the national level. So with that explanation, we work a lot on the capacity development of the workforce. So in order, so this, how do you call it? Harmonization, standardization?
Harmonization, I guess. Standardization is a similar concept.
That is, as you say, is a double sword, you say in English? Because there is a
double-edged sword, yeah.
From one side, it helps a lot to give the credibility to the people, the recognition they need and the training they need. But on the other side, as you said, it can actually take people, workforce out of places that are actually in critical need, specifically in places where salaries are not matched for that. So I think what is most important is to make sure that the recognition of those actually matters in that local context. For example, in Tbilisi, we've been twinning Georgia with Barcelona to get training on multidisciplinary care. What if they come back and there's not the guidelines and protocols to actually implement that training? So the training has to be able to be applicable in the context. If not, that's going to easily take them out of the country. The other one is that we have to see this as a circulation, not a loss. So yes, we all want, as professionals, to be trained outside, to get access to the best training. But also we have to find ways that these people can go back and apply some of the trainings in their countries. And we have a lot of examples of that also, like for example in Jordan, when they set up the King Hussein Cancer Center, they had an agreement with the National Cancer Institute of the US to bring the experts back and match their salary. So there's ways to think this as a circulary, not as a loss. And finally, it has to be linked to the needs. So if the trainings that we're setting only work for high-income countries and they are not applicable, then what's the purpose for the low-income countries if those trainings are not applicable in their contexts?
Neka, I want to come to you on this same point, really, the pros and the cons of harmonized credentials, and also just a reminder to the audience that we will have time for some questions and answers at the end. So if you do have questions, then please do save them, store them in your memory. Yes, so with MDoc Healthcare, presumably the harmonized credentials would really help you sort of use those digital platforms to really, to everyone's benefit. So are there cons or is it all pro?
Thank you so much. First of all, thank you so much for inviting me, and I'll also just highlight what MDoc does. So we provide virtual self-care health coaching that's also AI-enabled to people living with or at risk for NCDs. Today we serve about 150,000 people. We're headquartered in Nigeria. And we do that by linking people with human health coaches as well as an AI health coach. Our human health coaches are nurses, they are junior doctors, they are pharmacists. We also have an in-person element because we learned that digital literacy is not a proxy, mobile phone penetration rates are not proxies for digital literacy. And so we also, in our nudge hubs, where we are essentially like small mini clinics, we have community health workers that provide care as well. And so what we've recognized is that where harmonized credentialing can really play a role is one, in improving the quality of care, the quality of healthcare work, of health professionals. So today, if I kind of walk you through what we have to do to recruit these nurses and these doctors, I look at medicine, I look at nursing as an apprenticeship. You learn from the layers above you, but because we've suffered massive exodus of essentially healthcare workers from Nigeria, we're really recruiting healthcare professionals that have not been adequately trained. So imagine that you now have harmonized credentials at high-level global standards that these nurses, these doctors, these pharmacists are being held accountable to. My goodness, it would reduce the costs that I have to spend in terms of untraining and retraining. It's as basic as just being able to take a height and a waist circumference for a BMI. If I tell you the amount of training that we have to do at MDoc to nurses and physicians because they weren't adequately trained, or on how to take a blood pressure. So imagine what harmonized credentials would do in terms of completely changing the game in terms of quality. It would also reduce my costs. If I'm looking at becoming scalable and really becoming essentially functioning all over Africa and potentially globally, it would reduce the cost, improve operational efficiency. And the last piece is around digital, really kind of what we call digital fluidity. I can tell, I was trained even though I grew up in Nigeria, I was trained in the US as a pediatrician. And I can't tell you how many healthcare workers here have left the profession because they're frustrated. But they're reaching out to me to say, we want to become health coaches working in Nigeria. How can we do it? So we call that kind of digital fluidity. How can we facilitate healthcare workers from here to actually refine the joy and the intrinsic motivation that they had in becoming healthcare workers by actually working with us? And how can we also create opportunities for our health coaches to come to different countries and learn? And ultimately, that will drive improvement in population health outcomes at scale.
I think it's fascinating that you mentioned about the standards of care and that the fact that this is a good thing, the harmonized credentials is good for that, because certainly from conversations yesterday, that seemed to be a concern that actually you lose that patient-centered community, local level look at medicine and treatment and care by having a standardized, harmonized credentials across the board. But you're saying the opposite.
Absolutely. I don't agree with that. And so we do a lot of work in the AI space, and we've done a number of studies now that demonstrate that across board, AI, or even healthcare workers using AI in our context, so providing care to low-income population members, ensures higher, much more empathetic care, much more contextualized care, and this is even with a GPT or a large language model, right? So I think it's really, what it would do rather is put the pressure and quite frankly create marketplace dynamics that would ensure that private education and public education is essentially is provided at a much higher level. Today, we don't have the governance, we don't have the accountability that is ensuring that we have the right kind of healthcare providers. Quite frankly, it's not until they arrive here or in high-income countries that essentially you seem that because they have the resources, the policies are there to support them, they're paid appropriately, that translates into high-quality care for people. And so fundamentally, with harmonization of standards, we'd really be able to see that, we'd still be able to see the contextualized care. It really just, it would require the policies, the associated education materials, and the governance and accountability frameworks to facilitate that person-centered, dignified, respectful, and contextualized care.
You mentioned governance and policy quite a lot, so it's a neat segue to bring Guillaume into the conversation. From that policy-making governance perspective then, what are the pros and cons of harmonizing credentials? How do we convince policymakers that this is a good thing?
Thank you so much for having me. The discussion has been very good so far. I think we have been touching as well in certain aspects of the health system as a whole, not as the credentials or harmonization of the credentials of healthcare professionals. And I think that this leads us to an even bigger conversation, very interesting, but even bigger conversation in terms of what the pros and cons can be. So in terms of the policy making, I think this is a very political issue because we can look at it as harmonizing credential as, for example, the airplane industry, that you can have the same credentials all over the world and every country respects it, and you know that you have a certain standard of quality, which I think that in the end is one of the biggest needs to have this harmonization. Or you can look at it as well in a perspective of local contexts, of perspective of how you even look at healthcare. Because you can have this discussion, you can argue that healthcare is seen in different places in different ways. So this is, I'm not giving you a straight answer, I'm saying that this is a part of the discussion as how you want to look. And when you want to put in this ball in terms of what things are affected, you will have a lot of things. You'll have health professionals, corporate needs, interests, task shifting discussions. You'll have a lot of professionals not wanting to give certain aspects of the care. You have other professionals requesting that they are more into this participation. You have equity questions. Quality in there again, you want to guarantee that people don't lose faith or trust in the health system as it is. And you've been watching that a lot nowadays with vaccines, stuff that you take it for granted. So I think it's very risky as well. It's a very risky proposition to just reshuffle everything without a proper pathway. Having said this, I still think that it is a path that we should be doing together to understand what are the basic standards, what's the highest level of quality that we have to demand everywhere, because I think there are clear gains in terms of having a workforce related everywhere, so that people is comfortable in just going to other countries or migrating and knowing that they'll have a basic standards of care. And for this there are organizations, sorry, I'm gonna shut up immediately, but there is work that it can be done on a global level, either with WHO, but especially between countries, they have to sit at the table and decide this. And there's a way that then this can translate in local policies and how countries face this and apply to their health systems exactly these standards. So I think there is a way to go.
Go ahead.
Sorry, so one of the reasons why City Cancer Challenge was born was because there was so much innovation happening in high-income countries and in cancer and diagnostics that was not translated to the local context. And we had to actually work with the local stakeholders to find solutions that adapt to the local context, but matching those solutions with the international standards. So we were mobilizing the international community to support the locals to find their own solutions, but matching those with international standards. So I think that what we're seeing is a lot of the guidelines and protocols that are set up at the global level, they come from a high-income country perspective, and not only are they're not applicable in those contexts. So while I agree with you, Neka, that pushing for this quality, it's what helps, but I think that in order to make them sure it works for those contexts, they have to be part of the table. They have to be on the table. And we've discussed this, because it's always like, who is defining this harmonization is what worries me.
It's about trust, right? It has to be about trust as well.
Well, no, trust, it has to be about co-creation between, it's not about having, this high standards of the training needs. Well, maybe innovation in Nigeria is another type of innovation than in Germany. So low resource setting have to be part of the table of agreeing on the harmonization and what quality standards mean. It cannot be only the perspective of high-income countries, because then it's where we're going to have a higher inequity aspect.
And just adding to that, so to Isabel's point, it has to be equally yoked co-creation, because too often you see us play lip service or or folks from high-income countries pay lip service to the notion of co-creation. It's, okay, we just have to have kind of some token low-income members on the table. That's not it. It's really now those folks taking the time to understand the context in which care is delivered, and then the realities from a resource perspective, limitations from a financing perspective, the lack of policies therein, or the more constraining policies in which they're functioning. But I do think that the reality is, when we interview, I literally say to whoever it is, the nurse, the doctor, I say, how long are you going to give us? Literally, how long? How long are you going to give us? What are you What are you studying for? PLAB? So which country? And we're always met with almost like this shock, like, oh wow, should I say? Should I not? And my co-founder and I always say, just share with us. We're here. When you win, we win. If you can give us 1 month of dedicated time, we will invest in you and we will support you, right? I left Nigeria and I trained abroad and then I came back, right? And we know that you also will come back. During COVID, we had our teleeducation programs where we've trained 15,000 healthcare workers. Most of the time, we were able to find volunteer educators from the rest of the world, outside of Nigeria, people who had trained abroad, but who wanted to reconnect with not just Nigeria, but the continent and give back in a meaningful way that led to an increase of up to 20% knowledge gain in the health professionals that we trained. So we have real measures that highlight those types of benefits.
I want to take it back to the kind of like the policy level and the policymaker level as well. Guillaume was saying that it's a risky proposition. How do you then convince parliamentarians who work alongside Guillaume that this is not a risky proposition and that actually this is beneficial to you, even if it means arguably ceding some of your control or sovereignty?
Oh, it's for me?
Well, this was actually a question for Nneka.
The reality is they know they're going to leave. They're leaving. The evidence is there.
The workers.
The workers are leaving. Like, there's no, if you look at the headlines, particularly during COVID, or the WhatsApp groups, people were saying, oh, they've brought planes to come and carry our doctors away. So the question now is, how do we create an ecosystem? How do we shape market forces so that and leverage the power of the rest of the world to do what we have not been able to do in the last 20 years, which is completely own what the quality standards look like, right? By co-developing them with the rest of the world. How do we rethink migration policies? And to Isabella's point around circular migration, how do we actually think about loan or exchange programs so that we're sending folks, but people are also coming to us, right? Because the game when it comes to measurable improvement in population health outcomes, and then go to high-income countries and say, okay, we want to deliver on vaccine manufacturing. We want to become the regional hub for AI in health. And quite frankly, to be very frank, a lot of the innovation that is happening in AI globally when it comes to health is happening in Africa, right? And so we need to see more, ministers and country leaders then say to high-income countries, let's be partners on this. Again, equally yoked partners, and co-develop and create something where there's actually shared value. You benefit, we create those governance and accountability frameworks so that we hold ourselves accountable and track. I'm a firm believer in data, and so we leverage the power of data to actually track where we are and hold ourselves accountable.
You agree?
Yeah, absolutely, and I wanted to jump in on the data. I think you made a question before, and I think that it definitely can help, because when I was previously saying that, okay, we need to define, maybe we need to go after data and understand what the patients need, because as Nemo was saying very well, when you've got a pathway of care, then you have to understand what professionals you need to input in there. So maybe you don't need the traditional ones, you need a special ones, and you need, in a local context, perhaps an addition of a care, or just as a person will have the outcome that is desired. So I think that we also should be more based in data, be more based in not research, but immediately monitoring of the path of care, and I think that will also help us understand what do we need.
Yes, go ahead.
Sorry.
No, it's fine.
No, I want to give an example. So, for example, one of the professions that are actually having much more impact in terms of improvement of care in low-resource setting is patient navigators. For example, by embedding patient navigators in the system, we're able to reduce time from diagnostic and treatment, which you know for cancer is life-saving. And so I think this harmonization also should help to elevate some positions that are not, recognized, like patient navigators, even oncology nurses, cancer registrars. And I think that something that would be benefited for lower resource setting is the international recognition of these positions that are critical in care and not the traditional, the doctors and the and
but who are also obviously vital, but it's just that there are so many others as well.
This actually could help push, because in these settings, patient navigations are game changers. But I struggle to prove, even if I bring the evidence that we've done, as you know, with digital solutions to prove the evidence on reduction of time from diagnostic to treatment, still it's hard for them to embed it in their budgets.
Because all of us, Neko, when you mentioned about someone helping a child laugh and bringing a dog in, it sounds, we believe you because you're telling us now on a stage, but we don't necessarily have the enough evidence and data to understand it properly. I will come back to some more questions from me if time allows, but I want to open it up to the floor as well. If you do have a question, then please just raise your hand. I believe someone will come round with a microphone for you. Yes. 3 or 4 rows back, just on the side there, please. Is there just the lady over the side? If you wouldn't mind just stating your name and organisation, please, as well. Thank you.
Hi, sure, thanks. Yes, my name is Grace Kistner. I'm first a nurse. That's what I put everything out there first. The other hat that I wear today is the board of directors for the Society of Nurse Scientists, Innovators, Entrepreneurs, and Leaders. And I think a lot of the discussions that have happened today and yesterday have been about migration for nurses and other healthcare professionals and the credentialing that needs to go into that, the training, et cetera. And I think that's been focused on international migration mostly. But these are the solutions that we need for that are long-term to be done really well. But when we think about regional migration, right, international migration, we're talking about when these are choices, when they're not choices in terms of conflict, disaster, emergency, that may not cross borders. What are the more immediate term solutions, the first things that we can do to get towards this standardization of qualifications for nurses and other healthcare professionals to hit the ground running when they need to move without choice?
Thank you for your question. I don't know who wants to respond. Don't leave it to me.
I'm not in the, I'm sorry, I'm putting that because I want to say you better. I'm not in the humanitarian space. However, what I've seen, for example, I don't remember which city now, but there was a huge gap on oncology nurses. And of course, the data was telling us that we need to have more nurses in oncology. But actually, there was other sources of data that were showing that there was a lot of nurses unemployed. So maybe it's not about bringing more nurses on oncology, but actually recycling those nurses on oncology. So basic to your question, I think, the country should be ready for that, and maybe the nurses and a few set up, they should be ready and trained for those humanitarian crises. So that there has to be maybe part of that curriculum is how do we recycle quickly nurses or other doctors to actually what is their role in a humanitarian crisis situation. So yeah, sometimes we're always looking for additions, but it's just about how you train the available to actually cover the gaps. And this is system efficiency that is, because of the lack of data, we tend to not be efficient in the systems.
I wonder as well, because you mentioned about humanitarian crisis, but crises can also be in the form of like a pandemic and pandemic preparedness that we're all sort of so focused on now.
And also high resource versus low resource doesn't cross borders either necessarily. So the amount of quality and training that needs to go into this, the standards of this, are still sometimes within one country.
Yeah.
Or-
So we, for example, what we do is we do what works the best sometimes. It's not about sending people from Ghana. We've done it. We've sent people from Ghana to Mayo Clinic, and the feedback was really not as good as when, for example, we send it to the next level, to Morocco or our neighbor country. But even getting training from Kumasi to Accra is actually much more efficient than sending them abroad. So we tend to do a lot of cross-city training, so experts from one city to train others, and those probably are the most efficient. So south-to-south training, it's proven to be very, very efficient. But it's always good to also know what's next. Like you have to see what immediately next and what is the next stage and this, so that you actually know what's on the horizon.
There needs to be a good roadmap in place, yeah. Further questions? Yes, please. Oh, it's Kate. Hello.
Hi, good morning. This is Kate Talenko with Corvus Health. And the question I have is, with the support of Roche and Tata Trust, we've redesigned the cancer care team in India, Nigeria, and Cote d'Ivoire. And we've introduced new cadres, like you mentioned, Isabel, dosimetrists, medical physicists, and cancer GPs, which can do 80% of what an oncologist can. But the progress is slow. What can you do from a global platform and from a global perspective to speed up the adoption of these reforms? Thanks.
I think that you can elevate the power of the people that need that. People with cancer, their champions, their communities. We do not elevate the power, the voices of our patients, our members, the citizens enough. It starts there, because if you think about just even politics, politics are in service of the citizens, right? And so how do you create a platform, and how, I'll say, how do you leverage technology to elevate the voices and the demands? So one, in demonstrating through your pilots, how is that communicated? How is it fed back? And who is it fed back to, and how is that done? At MDoc, so at MDoc, we don't prescribe, we don't diagnose, we don't treat. Literally, we're there for you the 99.9% of the time you're out of a healthcare facility. But because of that, we recognize that we needed to be able to refer people to in-person care. And we support a lot of people with cancer. And so we created a geocoded directory of healthcare services, facilities, and providers, essentially a Google Maps for healthcare. But it's layered with a review system. And that review system is aligned with the quality domains from the National Academy of Science. Why? Because we wanted to galvanize healthcare providers to be more incentivized to actually focus on improving the patient experience of care, but in specific areas. So, hey, and not to feel that it was punitive, so that it would be, okay, you're not doing great on timeliness, but you're really doing, wonderful on effectiveness of care, right? And so, but why is that important, and why am I bringing up here? Because we've had over 23,000 patient reviews, primarily from low-income women. We held a gallery walk and pasted what women had said about their experience of care. Anything from, I came here to deliver a baby, thought I was going to leave with a healthy baby and I would be healthy. Instead, I came down with malaria and almost died just because they don't have mosquito nets for me. As basic and fundamental as that. We posted it around, and guess what? Our Ministry of Health said, look, are these the voices of low-income women? Women that basically almost make no money at all? This is how we can actually hear what matters to them. Guess what happened? They literally said, we want to mandate this in every single primary healthcare facility, this review system, to elevate their voices, because we're going to make change. Literally, we saw change happen overnight in primary healthcare facilities. Why can't we do that with cancer care? We don't hear the voices enough of the people with cancer. We hear, people say, oh, men, example in Nigeria, oh, men are not strong healthcare seekers. Bring a bunch of men who have prostate cancer together. They can make everything. Everybody in New York City would hear them today. So truly, let's create platforms for the people that we serve, and I promise you will see change overnight, because politicians care about them. And I'll stop.
Guillaume, if you can just add to that as well, maybe. Politicians care about the people, they care about the health workers. Is that reflective in the politicians, the policymakers that you work with? Big question, sorry.
No, absolutely, they do care. They do care about immediate gains, though. So my word of
and
caution...
they have short tenures as well.
Yeah,
so.
Exactly. So I think that the hard truth is I think that you have to prove the model. Like, it doesn't need that, you don't need to be like a very fan like Isabel is. Like, you know, we all love what we do in terms of our passion, and we are sure that that's the perfect model. I think that the model has to win to everything else. And in health system, I think there's another layer of complication, which is competing priorities. I mean, you care about cancer, then the diabetes fan will say, no, diabetes is the most important. You will battle with epidemiological data. You'll say about impact, about prevalence, about incidence, you know, and you'll have a question, and a politician will be confused. So I think that you do have to make your case very well, elevate, as very well said, and you do have to prove that it really improves in various tons of data. Cost effectiveness, efficiency of care, patient satisfaction, and then a couple of public health reasons as well. I mean, the number of cases avoided, etc., etc. If you do that, probably you'll have enough attention to have a proper investment.
Thank you. Any further questions from the floor? Yes, please. And please wave at me, everyone. If I miss you as well, just wave at me.
Dr. Melinda McKay from JSI. Dr. Movison, really interested in your comments about empathy and the use of AI. And I would like you to go into a little bit more detail about what conditions really set up the AI models that you use, particularly with all of the concern around implicit bias that is, you know, tends to be embedded, particularly for lower middle income countries. Thank you.
Thank you so much, Dr. McKay, for that question. So MDoc has been doing this work for the last 8 years, and I think our power is that we listen to the people that we serve, and we have historical multi-round member conversations between coach and member. Over 90% of the people we serve make less than $2 a day. So we're serving low-income people across the entire country. We've leveraged that to actually train our models, right? So when folks talk about the concerns around the implicit bias or the fact that these models have not necessarily been trained on systems, we're leveraging our own data to really fine-tune the models, and then we're co-designing with our members. So we've developed a rapid cycle user testing framework where we continuously test. I come from a quality improvement background, so it's all about, you know, micro-experimentation, putting people at the front. And so we leverage kind of those frameworks to continuously test in service of the people in our communities. And so I think that's been really critical. You know, I often challenge this notion that, oh, there's no data in low-income countries. There's data. You know, are people willing to make the investment to make it robust and make it, you know, high quality so that it can actually be used to train the AI systems? For us to even train, to use a small subset of our data, I had to hire so many more clinical experts to actually invest in making it robust and high quality, and also to account for the variation that happens when you have some healthcare workers that were trained in suboptimal medical or clinical education systems and some that were not. How do you, no one is really talking enough about that, that variation, and it's going to affect our AI systems, but I'll park that. So when you do that, what you get is actually really compassionate, empathetic systems that deliver care that potentially members have never experienced in their entire lives. And we have demonstrated this over and over again. We've been leveraging AI for the last 5 years, large language models for the last 2.5. And we have demonstrated this over and over and over again. LLM by itself, well-trained with contextualized data and done in a responsible and ethical way, performs much more empathetically, builds measurable trust, provides more accurate, safer, more complete guidance to a member than human with LLM, and which is even more than human with standard of care in our settings. We literally just submitted a paper on this 2 days ago. And I don't think we're talking enough about the fact that there are differential arenas where this matters. So a lot of our members who are really supposed to be coming to us for hypertension or diabetes or cancer care are now saying, I feel unsafe. I'm experiencing gender-based violence or the equivalent of that. Or I have a friend who took insecticide by mouth a few days ago. What should they do? So literally, suicidality, there's been a lot of documentation in the New York Times about what it's doing, but I think what it's doing is opening up, it's conferring anonymity, it's facilitating trust by being more empathetic than maybe the public hospital where you've been standing in line for 6 hours and the overworked, overburdened healthcare workers, not to any fault of their own, but really don't have the time to be empathetic or weren't trained in person-centered care. It offers dignity, respect, and anonymity in a way that they've never ever experienced in their lives. So what that's doing is giving me more sleepless nights, to be frank, because now it's like, how do we solve all these problems without the backing that we need to really, change the game? But there's a lot of opportunity in AI, and I will say its praises for despite the bias and despite the issues, there are issues, but there are a lot of opportunities for low-income country contexts.
Thank you so much. I hope that answers your question as well. Yes, please, right at the back.
Thank you. Morning, everybody. My name is Risa Turetsky. I'm a nurse practitioner here in the US. And I've also spent 5 years or so working in rural areas of Malawi, Papua New Guinea, and other countries in East Africa. And my focus is adolescents. I'm on the International Association for Adolescent Health Council. I run the education committee for both IAH and the Society for Adolescent Health and Medicine here. And one of the things that we're working on is how do we standardize or harmonize the curriculum. We've worked with the World Health Organization to develop core competencies that are meant to be international, but we keep getting this question of, if we make it all the same, how do we not dilute the quality in certain higher income countries to come to sort of the minimum that's needed to be able to implement? Like in the clinics that I've worked in rural Malawi, we're not implementing the kind of care and the kind of quality and how to deal with that. And then the other question is, how do you continue to ensure quality in these countries? Who's holding everybody accountable in systems where they're not built with the kind of infrastructure that some of our high-income countries are? And so my perspective is adolescence, but I think it's a more general question.
Thank you for your question. So, we've talked already about this idea of that it doesn't reduce quality of care, that harmonizing credentials wouldn't do that. And my understanding is that your question is, does it actually dilute standards of care as well? Isabel?
Yeah, I can respond on, starting with the second question. We at City Cancer Challenge, we work at the first round of implementation is around quality standards, so standardizing the cancer care across the city around pathology, imaging diagnostic, treatment, radiotherapy. And for us, it's critical. In cancer, there is no way, no quality is no high or low, it's quality. So basically how we do it is bringing communities of practice, so bringing cross-sector, all the different pathologies together, the imaging, diagnostic. Interesting, they are in the same city, but not all of them know each other, and not even, like they've never seen before each other, or they've known each other, but they never talk. So we co-create with them, and we bring, for example, when we talk about pathology standards, we partner with the American Society of Clinical Pathology, who assigns experts to work with the locals to set up what is standard of care in that context. And then the model is that it's done by the local stakeholders with international support, and then that is elevated at national level for policy endorsement. And we're currently in 16 cities, and I would say already 80% of our cities, all the quality standards, policies that were done at city level have been endorsed by the national government, because while we're working at City, I just want to emphasize that our counterpart is the national government. They need to approve this ground-up approach. So we set up quality of care from the ground up, and then there is a mandate from the government on the implementation across all the laboratories, and then we work on technical cooperation to make sure that the standard of care is set up, and of course then there's the quality improvement mechanism. And the other question, I think, what I've seen in guidelines is stratification approaches. So basically you say, okay, this is the non-negotiable, and then this is the other layer, and then there is the super layer. But you have to start setting up the non-negotiable, and the stratify approach works. Not everybody's in favor of that, but I think it works.
Just to add to that, I wonder whether the need is still the same, whatever the setting is. That if someone needs cancer treatment or cancer care, then the need is still the same. It's the resources that are available in order to treat that, and that, I guess, is, from your experience in rural Malawi, for example, that would be very different from Manhattan. So yes, I guess that's one of the challenges.
Yeah, so I appreciate you framing it that way, because it strikes a chord with me. I remember when I was a resident and I was working a resident in the US and working in Nairobi, and we had a very sick child that needed care. Sometimes I think because we train from a resource-poor context, what we're doing is we are removing critical thinking skills, problem-solving skills that are, I think, even more foundationally important than anything else when it comes to the healthcare workforce. We're not training folks because we're saying we don't have labs, we don't have diagnostic, we don't have the devices. We're not, and this is why it's so important to me to have harmonized credentials. When we're almost training our healthcare professionals to be victims of circumstance, as opposed to be critical problem solvers who learn how to leverage every single resource that they have at their fingertips to move towards the North Star, which is a healthy patient. It doesn't matter where you are in the world, patients define quality the same way. Do not harm me, heal me, be nice to me, in that order. So if we collectively work towards I like what Isabel said in terms of stratification, but if we work towards a North Star of assuming that we need to give every single person deserve, regardless of who they are, where they come from, deserves the optimal care, whether they're a 3-year-old with a leukemia in the US or in Ghana, they deserve to actually live because the data shows that they will live. Or if they're an adolescent, they deserve that right to care. I think it completely changes how we train, how we credential, how we essentially create the standards that will facilitate that care. So I caution all of us to, because I think we're doing it too many times in our own countries, we're holding ourselves to much lower standards than we should, and we're seeing it in the people that we're losing every single day that should be alive with us today. And I'll stop there.
Guillaume, you look like you were about to jump in at some point.
No, I wanted to give a step back into the quality and back to the question where the quality was again raised, and I think you, Anna, said that we had agreed that the quality was not gonna be reduced. But I want to challenge that idea and say that when you harmonize or when you make a standards, you will at some point limit the quality, and you're trying to get a medium, an average that you want to achieve, and it's the minimum standard. Which doesn't mean that at some point the process of innovation will not make that a bubble somewhere will be a higher quality. And I'm going to give a practical example also in terms of what we've been discussing. If we train our health professionals to ask for antimicrobial resistance tests every time there's an infectious process going on, then they are used to it. But if they go to lower standards, or the countries that don't have that accessible, which you'll be surprised, it's not a lot, like there's not that many availability every time because there's a lot of infections, usually just treat empirically. They will face this challenge of they're not able to provide the care as they were trained. This has two implications. One, they will ask the system to get it provided, which is good because it's a stress for the health system to adapt in terms of, no, we need to provide this. So this is an internal stress that will be good in terms of quality, at least in the future. Politicians will know we're lacking into these tests, we have to make this available, we have to make it happen. So this is an internal struggle in terms of resources.